Hello and welcome to the 11th session for the Principles of Exercise PET module. This week we're dealing with the big subject of exercise prescription. Remember, there's no such thing as a bad exercise, only bad exercise prescription for someone that is not adapted and conditioned to that task. So here you can see bottom left, my particular favourite. We've got a lady deadlifting some heavy weights, a middle-aged lady, and that's good to see. We don't see enough of that, okay? And we've also got an amputee in a wheelchair doing some weights as well. These are images you don't see of people training that we need to get out there more, rather than just people in hot pink lycra hot pants. So exercise prescription is going to be our theme for today, and we're going to apply the principles of exercise therapy to exercise prescription. We're going to rationalize how an exercise program satisfies these principles. We're going to formulate a list of appropriate exercises. We're going to teach some relevant exercises and receive feedback on our communication, and we're going to establish a components of fitness hierarchy. So remember, we've got our 10 components of fitness. Fess up if you've got an ab pack, okay? And there is a hierarchy when we're doing therapeutic exercise. So our centering statement, our mission slide, this is what physiotherapy is about. It's about human anatomy and physiology. It's about human movement and function. We're maximizing wellness and potential. We're minimizing disease and injury, and we're solving real world problems. So exercise prescription is the goal of what we're trying to do is to have this successful integration of the principles of exercise therapy and some behavioural techniques that motivate the patient to be compliant, thus achieving their goals as well as ours. So here are the principles of exercise therapy. Again and again, you need these firmly in your head. We've got adaptation, specificity, progression, regression, overload, reversibility, and time out. Then we've got behavioural change, individuality, lifestyle integration, the law of diminishing returns, and your responsibility. Okay, so if you're a fitness instructor, you might know the FITTE Principle, or the FITTE Principle as it is now. Frequency, how often; intensity, how hard; time, how long; type, what movement; E, enjoyment, what do they like doing. Okay, as a physiotherapist, we're going to go one stage further than this, because we're looking at the drive principle, which will be the duration. Okay, how long will the exercise be performed? The repetitions, how many repetitions of this particular exercise? The intensity, how much work is required to achieve the activity? The volume, this is how much work in total, the sets and the reps in a single session, and which energy system, anaerobic, lactic acid, or aerobic predominance. So let's just remind ourselves, what is exercise prescription? Exercise is medicine. We're prescribing a specific dosage of a powerful drug. It needs to be based on a needs analysis, and we'll do more on needs analysis next semester. This exercise on prescription is what we're doing. Remember that exercise is going to prevent long-term, provoke short-term, and exercise is a preventative health measure. Okay, so we've got to make sure that we do our screening correctly, a physical activity readiness questionnaire, making sure your patient is ready to exercise based on the risk-benefit ratio. Contraindications and precautions have all been checked, and we're going to cover things like movement screening, such as the single leg squat and the single leg loading program developed here at the University of Salford with Dr. Lee Harrington, Dr. Monroe, and others, to name just a few. So clinical reasoning is thinking about your thinking. So we're going to describe what task and what individual. We're going to observe the patient performing the task, and then we're going to link that task, or why they can't do the task, to our knowledge base. Why are they struggling with that particular task? We're going to come up with a hypothesis, okay, based on our experience and the evidence, and then we're going to implement that exercise. So what exercise would help? Is it a motor control issue? Is it a physical fitness issue? Okay, and then we're going to evaluate. We're going to test it and then retest it. Now, if it's a long-term physiological training effect, we're going to have to test it in a couple of months. If it's a motor control issue, we might test it at the end of the session. And does the training effect need to occur before the task can be completed? That's important. So behavioural change is the most important thing. If behaviour doesn't change, nothing changes. So behaviour will drive exercise adherence. If you don't adhere, you don't get results. You cannot get the results of the training you didn't do. So you've got to look at internal personal drivers. What's motivating that individual? Is it because they're lacking the drive, or is it because it's not fun? What barriers are there to doing this exercise? Things like, I haven't got enough time, I don't have enough energy, and we've got to negotiate these shared goals with the patient to get them moving. So individuality, person specific. Okay, we use a holistic approach. So body, mind, spirit. Okay, the whole being. So we've got to look at their work. Is their job good for them? Are they really physically active, or are they in a desk job? Do they hate their job, or do they love their job? Are they sleeping well? Are they getting 8 hours sleep? Okay, what's their sleep hygiene like? And how much play are they getting? That physical activity or exercise. We've got to look about their nutrition status, their hydration status, and their mental health. So their mood. Is their mood stable, or is it fluctuating from low to high? We've got to assess the person, and also their training status and experience. If you've got a previous Olympic athlete compared with a couch potato, you're going to train the two very differently. And also, are they injured, or do they have a history of injury? And all these results will be gained from a pre-screening test. Specificity, and this is about task-specific behaviour. So we've got to evaluate the task, their significant task. Yeah. So movement analysis, which functional movement pattern is being used? The physiological analysis, which component of fitness do they lack? And the injury analysis, which common sites for a joint and or muscle injury are the causative factors? So we come on to the 4 P's of functional movement. You've got to know the purpose, the position, the posture, and the pattern. The purpose is, why am I doing this movement? The position is, am I standing, lying, sitting, walking? The posture, where are my joints aligned? And the pattern could be any of your 7 primal patterns: squat, hinge, push, pull, gait, twist. So you check out that YouTube clip. There's an example of some bad exercise prescription. It's quite funny. I'll let you view that another time. Okay, so which component of fitness needs improving? Is it strength? Is it power? Is it speed? Is it range of movement? We've got to look and see which component are we going to work on. Then we've got to look at the task-specific considerations in their activities of daily living, things like washing and dressing. And then where are they having trouble, for instance, rolling over in bed? Is it from a lying position? Is there pain or there's discomfort or the disability in a sitting position, standing, walking, running, or jumping? So where in that level of tasks is their issue? We've got to make sure that we regress the movement. It's no good getting this baby to lift that weight. It just won't be able to do it. So we've got to make sure we regress. So what exercise are we talking about? Could be a press-up, could be a squat. What level is the patient? Is it too hard or too easy? And can we change the variety of the same exercise accordingly? Again, progression, you can see that this guy is absolutely finding that easy. He can do it with one hand. So we've got to move him on because that is too easy for him. So overload. So when we talk about load, we're talking about making something heavier. When we're talking about speed or intensity, it's doing the same amount of work but faster. And then we could also be doing it further with increased distance. Or we could be increasing the volume, the total volume, which is the sets and the reps. So here we've got a table that differentiates the difference between strength, power, hypertrophy, and muscular endurance. And it's massively important you get your head around this. If you can lift a weight more than 6 times, okay, you are not training strength. You're just not training it, because it's 85% or higher of your 1 repetition max. Okay, so if you can lift it more than 6 times, you're not training strength. And you want a good 2 to 5 minutes between sets of this. So when you're recruiting maximal motor units, I'd give yourself a good 5 minutes. Now, when we're doing power, if you're doing a single effort, the same principles would apply. You're going at 80 to 90% of your 1 repetition max, but you're only doing 1 or 2 reps. And again, give yourself a good 5 minutes to recover from this. If you're doing multiple efforts of power, then you want to drop that load right down to about 75-85%. And here you want to do between 3 and 5 reps, and again, give yourself a good 5 minutes recovery. For hypertrophy, this is the bodybuilders, and this is where 3 sets of 10 comes in, with a 90-second rest interval, anything between 65 and 85% of their 1 repetition max. And then muscular endurance will be at a much lower load, okay, anything less than 67% of your 1 repetition max, be doing about 3 sets, maybe more, okay, and you're going to be 12 to 15 repetitions of that with only a 30-second recovery in between sets. Okay, so know the difference between strength, power, hypertrophy, and endurance. That's important. So what does the UK government recommend about our dosages? Okay, we've got to be doing 150 minutes per week of moderate intensity activity. Okay, and you can break this down into bouts of 10 minutes. Okay, so it's called snacking on exercise, but really we want about 30 minutes, 5 days a week. I would say 22 minutes per day. A daily practice is a daily habit, and you need 66 days to be doing something continuously before it becomes habit forming. The alternative is that you do 75 minutes of vigorous activity exercise, and this can be spread across the week. Recently, in fact on the news today, most adults between 40 and 60 in the UK are not brisk walking for more than 10 minutes in a month, which is frankly shocking. Okay, this is why we're having massive issues with physical activity, and this is why you're prescribing exercise. So remember that we can, we want to stop people sitting for long periods of time and get them snacking on exercise, get them up from their desk every hour on the hour, get them moving about for 1 or 2 minutes. Okay, here's a nice schematic as well. 150 minutes, 22 minutes per day gives you 154 minutes. Minimize your time sitting. You want to be strength training twice a week, doing some yoga if you can. Okay, help with that mind-body connection, or 75 minutes of vigorous activity across the week. So exercising for health. So that cardiorespiratory component, we've got to get the heart and lungs working. So even if you're walking, brisk walking would be ideal as well, because it's a low impact version that will get you out of breath. It's a continuous movement, and this is the trouble is that lots of people are walking, but they're not walking fast enough to get the cardiorespiratory benefits. So get on your bike, go swimming, get on the rower, okay, or go running. Let's get that heart rate jacked up, so that when you recover, your heart rate's going to be lower. And then you've got to do 2 strength training sessions per week. Okay, create that overload. Okay, and I particularly recommended squatting, lunging, and deadlifting. Okay, because they use all the components, okay, of the whole body, although they're lower limb patterns. Okay, but get your legs strong, and the upper body will take care of itself. So outcome measures. We haven't really covered outcome measures because we do that in next semester. But I'm going to give you some examples. Knee to wall test for soleus. Single leg calf raise test would be strength endurance for the calf, the gastrocnemius. Okay, single leg step down test would control and test eccentric quads as well as balance and proprioception. The Y balance test that we'll show you next term. Basically, you're tapping to the front, you're tapping behind you out to the side, and you're tapping behind you across the midline on the inside. Grip dynamometers, so you're just squeezing as hard as you can, and we repeat that 3 times. And then the functional reach test, where you just stand still and then reach as far forward as you can without falling. So we're going to use the example of sit to stand, because this is a really good example. So what's our behavior? Maintaining functional independence and addressing barriers such as fear of falling in the elderly or those with disabilities. So we've got to get fear out of the equation and give them back their functional independence by helping them to stand up from a sitting position. Okay, particularly if they're elderly and they sit for long periods of time and maybe don't leave the house. Okay, we've got to consider that as the issue, that individual issue. So the task is getting up from a chair. What components of fitness are we going to need? So we're going to have a look at them attempt to get up out the chair. And it might be that they're just not fast enough. They're too slow trying to get their nose over the toes. Okay, it might be that they lack the ankle dorsiflexion, that ankle mobility, okay, or in their hips or their knees, so they just can't get that weight forward and get the nose over the toes. It might be that they're not leaning far forward enough, but they're not accurate enough with their movement, or they might not be able to coordinate leaning forward and driving through the heels at the same time. So we're going to give them a regression if they're struggling, or a progression if they're finding it easy. So we've got to teach the correct position to help them achieve the task. So in this sit to stand movement, we've got to make sure that their heels are beneath their body, that they're leaning forwards, so they're getting their nose over the toes, and that they drive through their heels with speed and power to create that lift. And then if we want to overload them, we're going to repeat this process a couple of times, well, lots of times as well. So we just drill that movement in the patient's head, that they feel confident and competent, and we do it to effectively they're tired. Okay? And you just grease the groove of that movement pattern. So what will happen is there will be a motor fitness adaptation that comes on pretty quick. And then there'll be the physical fitness that takes much longer to gain. Okay, that's why you've got to keep pushing it, because if you don't use it, you will lose it. And then recovery. Okay, you've got to make sure that you haven't pushed your patient so hard that he can't stand up and transfer to the commode. Okay, you've got to watch their fatigue levels as well. Okay, but most people will respond to training and be more active rather than fatigued. Reversibility, we talked about this already. Okay, use it or lose it. How often are they exercising? Is it enough to create a training effect? Okay, chances are most people are either undertraining or overtraining. And then the law of diminishing returns, this is where the patient hits the rehab plateau. To get them better is going to take so much longer that we'll just refer them for some maintenance. Okay, my pet hate is trying to solve a movement problem with a fitness solution. Let's not add fitness to dysfunctional movement. Let's work on that movement first and then add fitness. So we've got a components of fitness hierarchy. So if we're dealing with an injured joint, we want to start by regaining full range of movement. Then we want to work on motor control and stability of that joint. Then initially we could work on isolated strength, and when we get stronger, that strength then becomes endurance as we're able to do more reps. We then integrate that into the exercise. So again, you go from strength to endurance, and then you progress with some load or resistance. Once you're strong enough and you've got the endurance, then you can add speed to a functional movement, and then finally you add plyometric power. So what have we learnt at the end of this session? We've revised how to apply the principles of exercise prescription and exercise therapy. We've been able to rationalize how an exercise program satisfies these principles. We're going to formulate an appropriate exercise list, making sure that we do things like progression and regression. We're going to teach relevant exercises and also receive feedback on our communication. And we're going to establish that components of fitness hierarchy so that we're not doing plyometrics, okay, right at the beginning when we should be doing them at the end. Okay, thanks for listening, and we'll see you in the next podcast.